I had a talk on the endocrine treatment for prevention of breast cancer with special focus on new drugs. So we started by discussing the state of art, which is the use of either tamoxifen or raloxifene, two selective estrogen receptor modulators, which have been shown to decrease by 40 to 50% the incidence of breast cancer in high-risk individuals. And from that standpoint, we have discussed the new agents or the use of old agents in an innovative manner. Because I think that prevention has the issue of safety and the issue of cost, which are extremely important. Safety. We don't accept toxic agents for unaffected people who also may have to take the drug for years. So it's very important to me that we use drugs that have a wide post-marketing surveillance, and we know almost everything about side effects. Secondly, the cost is very important because we want drugs that can reach large segments of population, so that have a huge public health implication. So we are not really interested in the drug of the day, which will be extremely expensive, but has a little impact also, I would say, on underserved populations in developing countries. So this is the philosophy of our group, develop drugs for reduction of breast, prostate, colon, and lung cancer, the 4 big killers, at little cost and with safety as the first priority. We actually have several trials under place, both in the phase 3, so trials that look at the incidence as the primary outcome measure, or phase 2, which we like very much, that is to show the activity of a new drug using biomarkers as surrogate endpoints. We have several studies that have collected 50 centers or more around the countries. So it's very important that, people also from peripheral centers are involved in this kind of research. There is a huge interest in this type of activity. Of course, it's very challenging because we have, because of our choice of inexpensive drugs, we don't take support from pharmaceutical companies. So these are no-profit clinical trials. For instance, today I have showed the data on metformin, which is the anti-diabetic drug, out of patent from decades, very inexpensive, very safe. We have a huge interest now in breast cancer prevention, but of course there's no support from the companies because it's a generic. So it's challenging. We get money from the NCI in the United States, from several charities here in Italy, like the Italian Association for Cancer Research, the Italian League Against Cancer, as well as from other charities like the Susan Komen Breast Cancer Foundation and so forth. We are testing this hypothesis. There is a huge evidence from epidemiological studies. Women or say patients, diabetic patients on metformin have lower cancers than diabetic patients not on metformin. So when you see these findings, then you go to the lab and look at the effect of the drug in vitro, and you discover that actually it blocks the growth of breast cancer cell lines. And so, I mean, the evidence accumulates and is very exciting. And now we are in the clinical phase. We have a study which will be ready for a first look in a month. So what happens in the post-menopausal phase? What happens to people in Western countries as they age? They become fat, they don't exercise, they eat too much. So glucose goes up, insulin goes up to try to lower, and this is the insulin-resistant syndrome. And insulin is a very potent proliferating hormone for the breast, for the prostate, for the colon, for everything. And this is probably a very important target for future prevention